And welcome to the Dr. Bob Show. You ever worried about your heart? You wonder how it functions? Have you ever thought maybe you might need a heart cath? Has your doctor ever mentioned a heart cath? Do you know what a heart cath is? Do you know what information it can tell you about your heart? We'll be spending most of this show talking about heart caths. Some brand new advances that you're going to be very, very excited about it, and I'm going to learn as much as you are. My guest is Dr. Malcolm Foster. Dr. Foster is a board-certified cardiologist, is involved with heart catheterization, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about calcium. Are you taking too much calcium? What happens if calcium gets too high in the bloodstream? What's the cause of it? There are many causes. And if we have time, we've got a couple of eye questions. Maybe what causes a red eye or cataracts? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Malcolm Foster, board-certified cardiologist, and we're talking about heart catheterization. Malcolm, welcome to the Dr. Bob Show.
Thank you, Dr. Bob.
How long have you been doing heart caths?
For over 20 years now.
Over 20 years. Mm-hmm. Are they fun? Is it exciting to do? Are they all of them are like?
No, they're very fun and interesting. Right on the spot, we're able to make a diagnosis. So we have concerns about the heart, we do heart catheterization, and we can figure out what's going on with the patient. And then with intervention, if they have a blocked artery or a blocked heart valve, we can do an intervention right at the same time.
So when you do a heart cath, what information does it give you, and how do you do it concerning finding the coronary vessels?
Right, so when the heart pumps the blood, it goes out the arteries that are hollow tubes. So we go to an area of a pulse. Now, most commonly here in the wrist, the radial artery, we thread the catheter back to the heart.
What's the advantage of taking the radial artery versus down in the groin, the femoral artery?
Right. Here, there is very little chance of bleeding or complications. So it's much nicer for the patient. We can't always do it from the wrist, but most of the time we can. When we thread the catheter, we give X-ray dye, and that shows us if there is blockage in the heart arteries.
Now, the heart arteries, the coronary arteries, how do they get their blood? Where does their blood come from? Does the heart pump it out to them?
It does. In fact, those are the first branches as the heart pumps the blood to the aorta. So the very first branches are the right and left coronary arteries, which feed blood supply back to the heart.
How many coronary arteries are there?
Well, there's a right coronary and a left coronary, but typically we say there are three major branches, one to the front, one to the side, and one to the back and underneath.
Now, when you thread the catheter to the coronary artery, do you go inside those coronary arteries, or do you just throw a dye down in there? How do you visualize the coronary artery?
Well, basic catheterization or angiogram is to put the catheter to the origin of the vessel and give X-ray dye and watch the X-ray dye flow down the vessel. But we can go inside the vessel and use ultrasound called IVUS and see an image from within the vessel.
So you can do both. Now, when you're putting a dye in there and you look at a coronary artery, what does a good coronary artery look like and what's a bad one look like?
So from the time that we are young, these coronary arteries are smooth and wide open, and they have very rapid blood flow, and then it fills the heart muscle. When a diseased artery happens, that is when plaque buildup. So cholesterol plaque buildup narrows the artery.
Why do people get those plaques?
It's the risk factors, things like high cholesterol, high blood sugar, high blood pressure, and an interaction with smoking.
Yeah, smoking has always been a big one. How about stress? If I remember in Korea, they did some studies on autopsies on young soldiers.
Yes.
And they found that they had coronary artery plaques.
They do. So early atherosclerosis starts at a very young age. You can actually see it in young adults. And you asked about stress, and stress can certainly aggravate the problem, cause plaques to become unstable.
When you find an abnormal coronary artery, do you detect how many of those are abnormal, how much of the artery, how severe it is, and what can you do about it while you're there?
We do. We characterize it. So for example, we call it single vessel, two vessel, or triple vessel disease. And in general, if it's one or two vessel, we might think more about stent placement to treat the blockage. Whereas if it's triple vessel disease, particularly in a diabetic patient, we might think more towards bypass surgery rather than stents.
So tell me, what is a stent? What does it do? How effective is it?
So a stent is metal that is expanded by a balloon. So it's very small as it's threaded to the point of blockage. And then we expand open the stent, and that stretches the blockage and restores blood flow in that artery.
How do you find out where you are? I understand threading the catheter. I understand the dye going into the vessels. I understand finding a blockage there. How do you get the catheter to go to that blockage specifically and go through it in order to put in the stent?
Right, we do that under X-ray guidance primarily, and we have the ability to move the camera around at any angle and move the table. It's called a floating table, and so we can basically in 3 dimensions see the heart artery, and of course it's in a beating heart.
Which would make it more difficult.
It is.
So tell me, you're talking about a stent. We used to have angioplasty. You used to put a balloon in, open up, and then come out. Do they still do that, or they always put in a stent when you do angioplasty?
We still do angioplasty at times. In other parts of the blood vessels, we have drug-coated balloons, but in the heart, here in the U.S., we have conventional balloons. We have stents, and we have drug-eluting stents that put medication to the artery.
So drug-eluting stent, what does that do to the stent? How does that help the patient? How does that keep problems from occurring?
It prevents scar tissue formation. So from the time we open up the artery, on the spot it looks great, but we want to make sure that that artery does not re-narrow, that it does not develop a type of scar tissue, and the medication helps to prevent that.
How effective is it? How effective are stents? Well, what do they do to reestablish the flow? How long do they last?
So generally they last forever. So the need for repeat intervention is now less than 10%. So more than 90% of patients, when we treat with a stent, it's a one-time treatment for that spot, for that location.
What are the indications that you would look with heart cath for somebody that has abnormal coronary vessels? High cholesterol, chest pain, unexplained heart failure? What are the reasons you do a cath?
Yeah, probably the most common reason would be chest discomfort. So chest pain or tightness or heaviness. We also do it for congestive heart failure. And then, of course, in the setting of a heart attack, we do it as an emergency procedure.
So if somebody has a heart attack, one of those coronary vessels is blocked off, and right then you go in and open it up.
We do. It's 100% blocked, and we go in and reopen the artery and restore blood flow.
Is it important to be able to reestablish that blood flow as quickly as possible, and what is the timeline?
Yeah, very important. We say time is muscle, and so we try to get it done in less than 1 hour from the onset of the symptoms.
That's a big advance from what we did many years ago. It must be thrilling to watch the blood vessel open up and watch the heart reestablish its blood flow.
It does. People literally pink up right before our eyes. The pain is gone. They feel more comfortable. They're happy. They start telling jokes on the table.
Now, when somebody's having a heart cath done, are they awake or are they asleep?
They're comfortable. We try to give some sedation, but they can be awake. They don't have to be asleep.
So when you've done the cath and when you pull the catheter out and you've reestablished the blood flow, then the person has to start cardiac rehab or...
Yeah, we start the whole package: eating right, exercising, getting the weight down, stop smoking, Take your medications.
How long does that stent last? You said now it may last 10 years or longer.
Generally forever. That one spot, generally forever.
Are there other things that you can do in a heart cath other than just finding an abnormal artery? Can you see how the heart muscle works? Can you help a heart valve? Can you do other things via heart cath in the cath lab?
Yes, we can.
And that's what we're going to be talking about when we come back. It'll absolutely amaze you what they can do in the cath lab to help correct problems with the heart. And we'll be talking about those when we come back. We're talking with Dr. Malcolm Foster, board-certified cardiologist, and we've been talking about heart caths. Now, what I have in front of me here is a picture of an enlarged coronary artery. You can see right here there's a wide open hole, a little plaque, more plaque, more plaque. And apparently you can put a catheter in here and place a stent in there. Malcolm, show me what a stent looks like.
So the stent is very delicate. We expand the stent just like that.
So this is the stent right here.
That is a stent that would go in a heart artery.
So that goes in the middle of the artery, and then you blow up the balloon with your tire pump.
Correct.
And that opens it up and does the stent, which is metal, that immediately goes out and opens up?
It does. The stent stays, then we deflate the balloon, and the balloon is removed. So the balloon is just in there long enough to expand the stent. The stent is permanent.
I think that's so amazing. Is it difficult, more difficult than some people, if they've got a total occlusion? Do you have to ram it through there?
It is. We have a lot of tools to use, so if it's completely blocked, sometimes we have to use our extra tools.
It's nice to have one that's 70% or 80% because it's easier that way?
It is, yes.
And when you've got more than one vessel, like two different arteries, you say you can put in, that's better. If there's three, you sometimes have to think about bypass. How much time does it take to put in that stent?
Typically about an hour or less.
Let's go to the cath lab again. Let's forget the coronary vessels. We've already talked about if you have a heart attack, one of those vessels is completely occluded. You can go in and open that, establish the blood flow. If somebody's having chest pain, you can open up those vessels. What other things can we do in a cath lab to improve heart function or keep the heart from causing problems?
Right. So now, in the past, when a patient had narrowing of the aortic valve, for example, the main valve exiting the heart, they had to have open heart surgery to replace the valve.
What would go wrong with that valve? It would be insufficient or stenosis? What's the difference between those?
So we say sticky or leaky. By and large, the valve becomes thickened and sticky. It does not open properly. Leaky is a valve that can have leakage back and forth. Either one causes problems to the heart.
So the problems that causes the heart would be eventual heart failure?
Yes. Yes.
So can you correct that in the cath lab?
We can. We can now go in with a catheter procedure called TAVR, T-A-V-R.
What does that mean?
It's transcatheter aortic valve replacement.
Aortic valve replacement. So
Yes.
we're going to replace that whole valve.
That's right.
And then that's the valve. When the big heart pumps, it throws the blood out the aortic valve. If it gets sticky or if it gets leaky, you can fix them. So show me what you do.
So this is a model where the aortic valve was narrowed, and with a balloon catheter technique, we go in and place a stent valve, and again, deflate the balloon, take that away, and the stented valve remains open, and that releases that narrowed or stenotic valve.
Do that again for me.
Sure.
So this is going to go up through the artery.
That's right.
And you approach the aortic valve.
That's right.
And when you get there,
we expand the balloon, which expands the prosthesis. And then we deflate the balloon and remove that, and the valve remains. And so now they have an open valve and allows the heart to pump the blood forward.
Now, this looks awfully big to me to go through an artery to get to the heart. Is it all compressed down, and then when you blow up the balloon, it's up there and it
That's
stays?
exactly right. So it's all compressed on a catheter, and it's delivered. It's fairly small in profile, and then it's expanded open to be the proper size for that patient.
How does it stick where you want it to stick? I would be afraid it would fly away.
Yeah. Well, and they're very good about that. Actually, the valves are very well seated, and then they heal into place, and we've had excellent results.
Now, therefore, now when the heart beats, it's going to throw blood out through here.
Correct.
How long does this valve last?
Well, it's an excellent question. So far, it looks to be very comparable to the surgical valves that have been replaced with open heart surgery.
The valves that are done with open heart surgery, that means where you got to do surgery, you got what we call crack the chest. You got to open it up and do direct surgery on the heart right there. Here, you just do it all in the calf.
We do. And
Lab.
Surgical aortic valve replacement is very successful. It's excellent. But this is a much less invasive procedure to accomplish, the same thing.
How do you check to see if that's working a month down the road, 6 months down the road, a year down the road? What do you have to do to check on it?
We can do that with ultrasound called echo. So you can just put an echo probe and use ultrasound to take pictures of the valve.
And it'll tell you if that heart valve is working. So we can replace the aortic valve. Any other valves we can replace yet?
We're not replacing other valves, but we are working on a leaky mitral valve with what's called a mitral clip. And we can do that through the cath lab also.
Now, a lot of people have a mitral valve prolapse. I would call that a leaky mitral valve. Will these clips be able to fix that if they needed to be, or is it a more severe mitral?
It's more severe mitral regurgitation or a leaky mitral valve.
Now, with the heart, the big pump gets its blood from the left atrium through that mitral valve.
That's right.
And then when the heart beats, it closes that valve.
That's right.
So the blood throws out to the rest of the body. If the blood goes back, then it's not as efficient, and that's where the clip's going to work.
That's correct.
And you can do that in the lab.
We do that as well in the cath lab.
And right now they have to do something open heart if they can't do it in the cath lab.
Correct.
So tell me something else that the cath lab could do. How about the left atrium? A lot of people have an irregular rhythm called atrial fibrillation.
That's correct. And so we say AFib for short. It's very common, and it's associated with blood clots that go into the appendage and the possibility of stroke.
Now, what's the appendage? What does that mean?
It hangs off of the left atrium, kind of like the appendix hangs off the colon. And it's a source of where blood clots can form, and then they can be ejected out of the heart and cause a stroke.
Is that the most common place for a blood clot to occur in the left atrium with atrial fib?
That's exactly right.
And you've got something that can plug up that problem.
We do. This is called a Watchman device. Again, it's delivered through a catheter, and you can see it's a stent-like device, but it has a covering on the back. And so it plugs up the appendage, and when it does, it heals into place, no blood clots.
So that's amazing.
Yeah,
Well,
it's
now,
exciting.
if you're not going to have a blood clot there, the blood clot would go from the left atrium, left ventricle, and then the brain's the first shot.
Correct.
Tell me about how long it lasts. Does it mean you don't have to take blood thinner?
Well, that's the idea. This is actually a very good option for people that cannot take blood thinner. Blood thinner is the standard treatment if you have atrial fibrillation.
So this may keep us from having to do that.
In some patients.
What else? Do we have anything else here?
Sure, a couple more things.
Let's review here now. We've changed the aortic valve.
That's right.
Through a cath. We don't have to open up the heart. We've got a device that can block up the appendage. We've got a clip for the mitral valve.
That's right.
Looks to me like we're healing the whole heart.
We're doing a lot of it.
With CAS.
This is for a hole in the heart. So this is called a septal occluder.
Now tell me, a hole in the heart, what part of the heart, and how could there be a hole in the heart?
Well, this is typically, a person is born with this. So it's between the right side of the heart and the left side of the heart. So for example, an atrial septal defect between the two atria, or ventricular septal defect between the two ventricles.
So there's a hole between the two hearts, and the pressure makes the blood go where it shouldn't be going.
Correct.
And so you're going to plug that up just like a sink stopper?
Very close to that, and that's what this device is. So it's called a septal occluder, and again, it's placed with a catheter. We do this as an outpatient procedure.
Difficult? I mean, everything's difficult, but I mean, which one of these procedures is the hardest to do? You're amazing me, Malcolm.
Probably the TAVR procedure of replacing the valve has more complexity.
Anything you can see in the future that the cath lab's going to do?
Very much so. Stents will become bioresorbable so that you place it, but then over the period of 2 years or so, it reabsorbs completely.
And just left with an open artery.
That's right.
Very quickly, in 30 seconds, well, in the cath lab, can you measure pressures in the heart? Can you help people with heart failure?
We do. We can measure it in the cath lab, and then we can send them home with a little microchip. And so
that's small.
Yeah, so that's called a MEMS, cardio MEMS device, and it's a microchip, and we can measure their pressure wirelessly on a daily basis.
And so you measure the pressure that's in the valve that's going to the lungs for heart failure.
That's right.
Malcolm, it's amazing. You guys are getting too smart.
It's very exciting.
Isn't it exciting as can be? Mm-hmm. Thank you for coming to teach us. You're a wonderful teacher, and I think this is the most exciting show we've had in a long, long, long time. Thank you for teaching us.
Thank you.
Well, know that that bad heart can be a good heart without even having surgery, maybe, in the cath lab. And now you're going to want to stay tuned. We'll be talking about calcium. Why does the calcium level get too high in the blood, and what happens when that occurs, and some eye problems if we have time. I want to thank Dr. Malcolm Foster. Wonderful discussion on heart cath and everything that can be done in a cath lab. And now for questions from you, the viewer, that I think will be important to your health. Dr. Bob, is there ever a problem with taking too much calcium? Well, let's talk about calcium in the bloodstream, because sometimes when the doctor gets blood work, he finds an elevated calcium level. It may not be because you're taking in too much calcium. There are some other things that can cause it. Number one, there are parathyroid glands hiding behind the thyroid gland in the neck. And those are responsible for bringing calcium out of bones into the bloodstream. Sometimes if there's a parathyroid tumor, adenoma, it puts out too much hormone, brings up too much calcium in the bloodstream. And when we get too much calcium in the bloodstream, our muscles can get weak, we can get agitated, we could have depression, we could have nausea, we could have constipation. So there are a lot of things that can cause, that an elevated calcium can cause. Now, other causes, sometimes a tumor in the lungs can cause an elevated calcium. Sometimes it's too much calcium and vitamin D that we take as supplements, and there's a condition in the kidneys where the kidney doesn't put out enough calcium, and therefore it finds itself to the bloodstream. So if your doctor finds an elevated calcium, it has to be worked up. You have to find the cause, and then you can find the treatment for that. Question number two, Dr. Bob, what are some causes of a red eye? Well, sometimes a red eye, if it's only in one eye, could be where you scratch the eye. It could be that you've got the pink eye, you've got an infection in that eye that makes it red. If it's both eyes, it could be a dry eye syndrome. When the eyes get dry, they get scratchy and we blink a lot and the eyes can be red. Sometimes when both eyes are red, it could be allergies. Allergies cause a red, itchy eye. So a red eye that doesn't go away, sometimes we put in eye drops, and the eye drops are there to make the red eyes go away, but because of the eye drop, they come right back. So if your red eye persists and it bothers you, it probably is not due to something harmful, but you can talk to your eye doctor and he can tell you exactly what needs to be done for that. Well, that's all the time that we have for this show. I hope you've enjoyed it as much as I have. Remember the things that we want to do to stay healthy. Number one, exercise. I can't overemphasize how important exercise is to your health. It doesn't have to be running full pace. You don't have to be a sweat hog with your exercise. You just need to grab your tennis shoes and get out and walk, go ride a bicycle, swim, walk around the mall, have a good time exercising. Because when you exercise, it will help you keep the weight that you want. It will reduce stress. It lowers the blood pressure. It makes you feel good. A runner's high is an exercise high, where chemicals from the brain will tell you you feel good. So exercise. Number one, eating properly. The eating has to be a problem in the United States. We're marketed to eat. We look at television, we see all the good food that's there. Cut down on your portions. Look at the food you're about to eat and know that you need to eat the right kind of foods. Push away the fatty foods. Push away the fried foods. Bring on the whole grains. Bring on the fruits. Bring on the salads. Bring on the vegetables. Make your meat size the size of a deck of cards. Don't eat such big meals. 8 hours of sleep, 7.5 to 8 hours of sleep. Very important to overall health. When people are not sleeping well, it puts a stress on the body. When it puts a stress on the body, we can get high blood pressure, we can get heart rhythm problems, we don't perform well, we're irritable, people around us are not happy. If you're not sleeping well, talk it over with your doctor. And most of all, what is it that we like in the Dr. Bob Show? I wish everybody could laugh and giggle all day, because the people around you would be happier, you'll be fun. Find that person that you can laugh with, tell funny stories, tell childhood stories, tell something that happened that day. You'll laugh a lot and you'll stay healthy.